So thank you all very much. Very informative. We really just heard our multiple successful efforts to really assure health insurance literacy, and not only health insurance literacy, but beyond. This was just beyond health insurance literacy, which was excellent, and varied consumers of healthcare. So we appreciate it, and thank you very, very much. We have time to open this up for discussion, and we'll start with the roundtable members first. Winston.
Winston Wong, a member of the Roundtable. I was very intrigued by the MadPow presentation, as well as the folks from Consumer Checkbook. And Young and Invincibles. Because I think of, what's the opposite of Young and Invincibles? Old and decrepit, right? And I wonder... Yes. But the question I have, though, is I wonder are we trying to sell the same product to the old and decrepit to the young and invincible? Because if we are, I think that might be a losing proposition. And I wondered if there had, among all these folks that I mentioned, if there had been some intentional thinking about the vernacular that resonates with the remaining folks that still are on the sidelines in terms of the marketplaces, okay? Which, as I understood, we're not the old and decrepit. We're the more young and invincibles, or at least people that don't see themselves as old and decrepit. So the question is there room for a vernacular that really crosses over to the question of health literacy? So, for example, when we're talking to a group of people who are sitting on the sidelines, is it more attractive to talk about group purchasing or crowdsourcing as a way to frame the question of why insurance as a national imperative is important to spread risk, for example?
Good point. I mean, I think it comes down to understanding what will resonate with the population you're focusing on and customizing the experience to that extent. We always, in order to design for all, we can come up with kind of a very homogenized experience, and there's risk in that, but providing for different languages, different ages, different viewpoints, and I think somebody pointed out earlier an excellent point about what do people value, and framing the information and within the context of that is very, very important. And also, you know, what is going to persuade them? Is it social? Is it and that gets back to what they value. And you may be able to find patterns from demographic to demographic in terms of things that will resonate most.
Yeah, I would agree with that, and I would say that there isn't going to be one answer for everybody, either in terms of what we say, how we say it, or how we reach people, you know, how we get their attention. And I just think there have to be, you know, a lot of different things. But the core, you know, the core things that relate to what I was talking about, I do think, when put in the right language, are really the core things for most people. I mean, I do think cost and provider availability, but making those things resonate as real and the things that can affect your life does require reaching in different ways and communicating in different ways.
Cindy?
Yes, my question is for Dara Taylor, and I was very interested to hear you describe how you took the sentiments that you collected from those learning meetings with the patient navigators, and you floated them up to the White House, to HHS, et cetera. I was wondering if there were any health literacy recommendations or implications, learnings from that you could share with us, because many of us operate on a national level and would love to hear what we should be hearing from the front lines.
Sure. Thanks for that question. Interesting enough, I really believe that the majority of the challenges are rooted in health literacy in terms of what is identified at the local level. These are questions such as income inconsistency and paperwork that is received from a consumer when they apply for coverage through the marketplace. They get letters and notices saying that they haven't submitted the proper documentation on their income or their eligibility status in terms of immigration, and that's giving feedback to HHS to say that the letters and documents and notices that they're sending out to consumers don't have sufficient information or do not specifically explain what type of information is still missing. And these are several notices. One consumer can get 4 different notices, and some of the notices actually say different things, but still are not completely sufficient. So when we're hearing that that's a problem across the country, because the notices are the same from the marketplace, those are the types of things that we send back up to HHS, and that's completely a health literacy piece in terms of really trying to make sure that that document has all the information that's necessary, is written in plain language so that the everyday consumer can understand it, and those are the types of examples that we're flagging for HHS. And in some cases, there actually have been changes that have been made since the start of the first open enrollment period back in the fall of 2013. And I think I have to absolutely give HHS credit. Every concern that is flagged for them, they are genuinely concerned about. And there definitely have been some changes that have happened over the course of the years, and others that I have no doubt will be continue to be addressed as we move forward.
Linda?
I don't really have a question. I just wanted to connect some dots about the medical bill challenge. And Amy, you may not know, because I think the face to you has been HHS, but I wanted you to know that behind the scenes, this group working with the HHS Working Group on Health Literacy put together criteria for health literacy that's a part of the challenge. So I think we spent like one morning here after one of the workshops developing criteria that added into what HHS was doing. In addition to that, a number of our members have been contributing to the effort. Humana, so Kim Parson is here, and I know that they helped kind of express the pain points that patients have about the medical bills. And Steve, Humana, I think, has got a couple of...
United.
Pardon me?
United.
Health group.
Sorry, Humana, Optum, and a couple of units of United are going to be competing. Ruth, I think you helped with some of the understanding some of the problems as well. So it's really been fun to be kind of swirling around in the middle of what has been a virtual process. I will just say that going forward, Michael is going to be one of the judges. And so the HHS Working Group will be screening some of these applications. So we'll get to see some of the interesting design applications as we kind of look through them to try to narrow down the 400 applications to ones that the final judges will be reviewing. So it's really been interesting for me to see how health literacy fits into this kind of human-centered design and the overlap between those two. So it's been a really fun project, and I just want to thank everybody here for helping to contribute, and Amy for MadPow for working with Health 2.0 and HHS for this really interesting public-private sector collaboration.
Thank you, Linda, for that.
Thank you so much for pointing that out. So many people contributed to this, whether it was stakeholder interviews at insurance companies, health systems. There were so many groups. In fact, Community Catalyst participated as well. So really, I mean, there were 20, 30 different people, organizations that contributed to it, and that's what's leading to the very exciting quality and prospect of what's going to come out of it. So thank you so much for pointing that out.
We have a little time measurement to accomplish so we can get to the next panel. So I'm going to take Michael, Ruth, and James, go on to the break, and then the next panel. And if there's time for questions to add on, we'll do that later. So Michael.
I'll just truncate
No, you can.
then.
You have your time.
Okay. Michael Paciuola from Boston Medical Center. Recently doing some usability studies by us, 40% of the folks from my clinic in our usability studies couldn't use a mouse. So you are not on the same page. We're not on the same page at all when we think about the user interface that we're talking about that's needed and the kind of creative possibilities that need to be thought of to get past and into that space where it's actually, intuitive design is intuitive for the people for whom it's intuitive. And otherwise it's not. And so literally, so we do stuff with human-computer interactions with avatars. Sometimes the avatar comes on the screen and the patient comes in and waves at the character because the character is waving at them. And you say, no, you have to touch the screen. Really? Touch the screen? Touch the screen? And then you can get it to go. But it's not something that's, and not to mention all the other neurocognitive barriers. The boxes are too small, the person's hand moves, all these things have to get worked out. So it's nice to think about but we need to have a whole new arena of creativity. And then to just bring back the comments from the first panel this morning, which was, we need the human interaction.
So Michael, you have to invite me to make rounds with you sometime.
Just one point in that. Accessibility is hugely important, and that's language, that's disability, cognitive and otherwise, and there's a hugely important thing called universal design, and it gets lost. And so designing for extremes, so thinking about the family that has 16 kids, and thinking about the person that lives on an island and has to take a boat, and thinking about the person who has 5 chronic conditions that they're managing. So I think we tend to scope out extreme cases when we're thinking about it, but if we design for extremes, we'll actually make things better for everybody. So it's a really good point.
Ruth?
Parker, so I'm so glad Consumer Checkbook came back again 3 years later. I remember your talk before and thought it was incredible. So I wanted to ask you, looking back over the last, since you were here before, you mentioned these 4 components, key components of a good tool. I wonder, how much progress have we made on those 4? Where are we? Can you rate them for us? And where we stand on getting what it is we need in each of those 4 to actually have good information in order to create the good tool. Give us a little progress report on that. Thanks.
Yeah, thanks for asking. I was wanting to clarify that. I think there has been some progress on all those fronts. For instance, if I look at the federally facilitated marketplace tool, there is some total cost figure that you can come up with, and it doesn't loom large for you, but you can come up with it if you ask for it, and that's progress. How good that cost figure is and how much it relates to your particular circumstance, I think is still, I think it's not there yet, but at least it's on the table with regard to the provider directory. Information, actually the federal tool lets you put in names of doctors and you find out if they are, which plans they are in. A lot of better things could be done in terms of provider directories. Why don't you say something about, even about provider directories and what it would make it easier to go down that path.
There we go. So he says that because I get pretty deep and dirty with that data. As many of you know, that data still has some problems with accuracy. So, and I guess I would say it overall reflects that a great deal of that information was still designed to flow between the provider and the insurer, and not as much to flow between the provider and the consumer. So I think we're still, a really potent example of that is that you can't really identify your plan in a unique way, like a serial number on your TV. You can always find the serial number on your TV. You can't find a serial number on your plan or your network. So when you go to look at ZocDoc and you go to ask if your doctor is in network, you have to I mean, I have a slide for this, but you have to figure out whether you're in the UHC Choice Plus or the UHC Choice, and whether that plan, right? I mean, we still need a little more progress there, and I think, and right, and my sense is, and maybe the insurance folks in the room can speak to this, that the identifiers that come from the regulatory bodies are not enough, that there might be more going on that needs to be available to the consumer. And then on the formulary side, we haven't talked about that, but formularies, if you think about the country adopting NPI to be able to uniquely identify a doctor, I think formularies are still marching down that path. So when we look at drugs, which we're doing, it's still a little hard to relate a drug exactly to which one it is, and so more progress is needed there. I would say the fact that the healthcare.gov forced the release of provider directories was a profoundly positive step in that it changed people's expectations. They sort of really started thinking, hey, I should be able to look up for a doctor, and hopefully that will kind of continue to move forward and get past the barriers that exist.
James?
I was just going to comment that it reminds me of almost a container pill bottle and a medication label. That's what's ending up in the hand of a consumer. But what it represents is so much more than that, and the medical bill really is sitting in the hand of the consumer, but represents a lot of devil in the details that we are still working on, I guess.
Good afternoon. Jay Duig, member of the Roundtable. Thank you all for your terrific presentations. I'm interested in how you're sharing learnings about your process. I thought several of you touched on this, and Amy, I'm most familiar with it within your space of human-centered design. So looking at not just the endpoints of what's working or what worked on individual designs themselves, and then sharing them as examples for someone to go ahead and take and build on, but talk about that process of evaluation and what worked within those areas. So for, really when you're talking about having 400 different designers and firms come in, and then looking at, I was looking at a bill you can understand, the ratings that'll go on and the scoring that Michael will take part in, so in choosing the winners, but also capturing that information of what went on for, okay, this is what informed the design and development process. This is what worked, because I think a major contribution that the Roundtable has made over its course is moving away from the idea that you can have a 10-point checklist and that these are the principles and that they're always applicable, but it's more the interaction between all of this parts of the user interface, the system, and also the larger use environment. So how will those learnings about the process be shared?
It's an awesome point. I mean, I've learned so much today of things that I wish I knew a few years ago, and am happy that I know now, and looking at some opportunities for collaboration. But you make a good point. There's two different, well, there's many different types of design, but there's what's called research-inspired design, where you talk to folks, you understand, you ask them, what do you want? What do you need? And they tell you. But just because somebody asks for a big purple button doesn't mean a big purple button is what they really need, right? So there's some translation that occurs, but there's that, and then there's genius design, which is what Steve Jobs at Apple did with the iPhone. If you ask somebody, do you need your entire music collection in your pocket, they'd look at you like you were crazy. No, I have CDs, I have records, what are you talking about? So there's the two different methods. Now, the winning entry may have been inspired through research to come up with kind of a genius approach, or they may have very meticulously figured out what different folks need, find the patterns, and kind of go from there. But you make a good point, because when we point out who won and post those winning designs, there will be a lot of learnings that could be lost. And so what we will do is publish patterns and findings in what we learned combing through that sea of responses, so we can get some greater insight from it. But one thing we'd like to do too is kind of pull together information and resources on how to design the best plan selection tools like you guys are working on. What would the best experience be like, or what are all of the resources available? Because like I said, I'm just finding out about stuff today, and the insurance companies that I work with, I'm not sure that they're aware of this either. So it's a good point.
Jay, thank you for that point. So thank you very much. We will take, thanks very much, everybody, once again. We will take a 15-minute break and then come back for the last panel, which will be moderated by Ruth Parker.